Welcome everyone to our webinar on the latest treatments to manage menopausal symptoms, why you shouldn't just learn to live with it. Hello, I'm Michelle McDonald-Worstuck. I'm a registered dietitian that works at the Hamilton Family Health Team, and I also work as the nutrition coordinator here at the Hamilton Family Health Team. And I'm joined with some of my colleagues.
My name is Melissa Home. I'm a physician assistant with the Hamilton Family Health Team. I work in 2 practices, and I've been part of the family health team for the past 8 years.
And hi, I'm Dragana Skokovic-Sanjic. I'm a clinical pharmacist and also menopause practitioner. And I've been working with the Hamilton Family Health Team for the past 10 years.
Great. So we're very glad that you can join us for this webinar. We have lots of information to share with you, and we're hoping that you can share your questions and your comments with us through the chat box. We're going to have a time for questions at the end of this session. So we're going to go through some information first to get started. So let's get started. So we've introduced who we are. After attending this webinar, we hope you have a better understanding of why we need to manage menopausal symptoms and learn about some of the links between some of the vasomotor symptoms with our health outcomes. We want to talk a little bit about lifestyle strategies, as well as we want to talk about hormone therapy and some of the newer research is showing how to use hormone therapy safely and effectively. And most importantly, we want to help inform you so that you feel comfortable and confident talking with your healthcare provider about any of your concerns. So we're going to start with a true or false. So here's a true or false question for you. Less than 20% of women report symptoms of menopause, like hot flashes, night sweats, difficulty sleeping, concentrating, and changes in vaginal dryness and atrophy. Is that true or false? If you guessed false, you're correct. Actually, we get almost up to 80% of women are reporting symptoms associated with menopause. And some of the symptoms are listed here, and we're going to be going through this in more detail throughout the conversation that we have today over lunch. So you can see symptoms ranging from mood changes to insomnia to changes in cognition, etc. So stay tuned for more details on that. Another true and false for you. Vasomotor symptoms in menopause are associated with a higher incidence of cardiovascular disease and depression. And the answer is true. So the presence of moderate to severe vasomotor symptoms introduces cardiovascular instability, increasing the risk of cardiovascular events. And again, we'll be talking about this in more detail. True or false? Dietary and lifestyle strategies can reduce menopausal symptoms and reduce the risk of heart disease. As a dietitian, I'm happy to say that that is actually true, that healthy eating can make a significant difference to managing menopausal symptoms, as well as improving health outcomes. And really optimizing the diet is one way to reduce the risk of chronic diseases like diabetes and heart health, and to promote menopausal health. In fact, the literature shows that following a Mediterranean style of eating has actually significant benefits on cardiovascular disease and may in fact improve some of the vasomotor symptoms that we see with menopause. And of course, we'll talk more about that. Now I'm going to pass the screen over to Dragana to introduce some more information on hormone therapy.
That's great. And a question was whether the hormone therapy is safe and effective for treating menopausal symptoms. So this question really does not have answer that is true or false. As you can see here, it depends. It depends when the hormone therapy is started. So you can see the line here that looks like a 0. It's absolute risk, which means you are not at risk or there's no benefit. Anything that is below a line, it means indicates reduced risk with the hormone therapy. Anything above line indicates increased risk with the hormone therapy. So as you can see, those dark lines are trending towards protection. And this happens if the hormone therapy is started early in life or earlier in the menopause between ages of 50 and 59. So the question for this, the answer for this question is not really true or false. So basically, let's start at the beginning. You know, what are the stages of change and why this time is fairly confusing? And I'm guessing some of you are experiencing symptoms or are interested to learn more what's coming. So we like to see what hormones really have to do with it. We have many patients, we have many friends that says that, we have this menopause thing happening. What should I do? When they say menopause thing, they kind of use this as an umbrella statement for anything that it could be related to hormones. So just to clarify the terminology, what is the perimenopause? We hear lots about perimenopause or postmenopause. And starting with the changes that sometimes happen early in life, which is premature menopause, that anything that happens before age of 40, which is fairly, I would say, common as well. It could be that is a premature ovarian failure, that ovaries are not working properly, but that could also be transient, does not have to be permanent. It could be over-exercising, eating disorders, etc. But also there's a ovarian insufficiency that is primary, and that basically leads to stopping having a period and onset of menopause with very early age. And again, perimenopause is something that is around menopause, so time leading to menopause and few years after the last menstrual period. And this is, I would say, most confusing time in the transition. It's time when we have unpredictable bleeding, unpredictable symptoms, and they seem to be more dramatic than later in postmenopause. This illustrates what happens with our hormones. The first graph, lines going up and down in predictable fashion, are things that change in our body monthly when we have premenopause. That means in our childbearing age, when we are younger, we have periods fairly regularly. Some hormones go up and then they go down. So there are surges of estrogen that are predictable, also progesterone as well. The middle graph looks like you gave your kids crayons to play with. Those are lines indicating unpredictable patterns that happen with the hormone production in our body when we are in perimenopause. And perimenopause can last for years. Postmenopause, as you can see, those are a bit of a flat lines. It's predictable, very low estrogen and progesterone, and very high hormones trying to stimulate production of those two. So this is just a kind of a visual to illustrate the confusion that our body is going through in perimenopause. The menopause itself is actually, by definition, one day. It's the anchor point in a time that is defined the 12th month after the last menstrual period or final menstrual period. So kind of a good news, it's one day only. But again, everything leading to it and after is associated with lots of symptoms. What's interesting is that in our society, in Western world, in North America, the average age of menopause is 51. So interesting quote I found, that there's no wisdom in menopause. Basically we have wisdom in menopause, wisdom with aging, but there's only heat. That's what my patients tell me. So what are the symptoms and what is the prevalence of symptoms? Here you have some of the symptoms that are listed and occurrences per 100 patients, premenopause, late perimenopause, and 2 years after the last menstrual period. And the numbers kind of indicate that lack of energy can happen at any time. Depression tends to be peaking in a late perimenopause. Aches and joint pain are very common symptoms of hormonal changes in the menopause. Insomnia gets really worse as we age. Memory changes as well. And again, vasomotor symptoms are those hallmark, the hot flashes and night sweats. They really peak in the late perimenopause, and they kind of stay strong throughout the postmenopause. We do start experiencing vaginal issues, bladder issues at that time. Sexual dysfunction gets worse with age, dry mouth, and there's just some of the list of symptoms we have that are associated with the changes in hormones. So vasomotor symptoms, those hot flashes or power surges that people call them sometimes, they are really something that it can be very disrupting for women. And again, they are transient. They last a couple of minutes, but they seem to last hours. They're very intense quite often. They can cause flushing, sweating. The skin temperature increases and then it drops again. So there's always a bit of a sweating followed by chills, and that can be fairly dramatic. What happens when our body is actually increasing body temperature so dramatically, we actually pull resources of the cardiovascular system. Blood vessels start misbehaving, and blood pressure increases temporarily as well. Heart rate goes up, which causes a bit of a cardiovascular instability. Sleep is affected in menopause. Lots of women report issues with the sleep, sometimes associated with the hot flashes at night, sometimes just issue with the sleep. And again, if you cannot sleep, you get tired, you are irritable, there is issue with the mood. Changes with the bleeding happens in perimenopause. Irregular bleeding is very often. There is no definition for irregular bleeding. It's something that is outside of your regular pattern by frequency or by the amount of blood loss. And again, that could last up to 8 years before the final menstrual period. There is a long list of the genital symptoms that is associated with vaginal atrophy that can lead to some of the permanent and problems that really need to be addressed before they become a huge problem. So dryness, itching, burning, pain, discomfort, bladder issues, prolapse, etc. Sexual health is an issue on its own, but it does seem to be peaking when we are going through the change. And then there's definitely a connection with a low estrogen and decline in vaginal lubrication elasticity, sometimes associated with pain. But ovaries, when they're shutting down, they do not produce enough estrogen, and also they reduce the production of testosterone, which is usually one that guides our sexual desire and sensation. So I also like this illustration to show, in men, that the sexual response is kind of on and off. And in women, we have to be very fine-tuned to engage and respond appropriately. So again, mood is affected. It could be also not only related to the hormones, but associated symptoms, and definitely the previous history of the premenstrual syndrome, stress in your life, sexual dysfunction, physical inactivity, and poor diet can also affect the mood. So number of us going through menopause and living post-menopause is growing in North America, and it's growing by leaps and bounds. So it's more of us should be looking for help and seeking attention for our symptoms. So we don't really have to learn to live with it. One of the issues that we like to address today is the hormonal therapy. Every time I speak with my patients and mention hormones, they tell me, oh, no, I don't want to talk about hormones. They are bad for me. They'll kill me. So the question is, why is the hormonal therapy in menopause so controversial and still very controversial? Quick history. In 1930s and earlier, we have started with experimenting with using different kind of extracts from ovaries of different animals and mammals and to get estrogen and to give it to menopausal women. That was leading with research to 1942 when the first estrogen tablet was patented and sold, and then the sales of it and use of it was increasing up to late 90s. That was one of the most prescribed medications globally. And then 2002 happened. And in 2002, we had one of the largest studies done using hormones in women in North America. And the study, one arm of that study stopped in 2002 and second arm of the study in 2004. The arm that was stopped in 2002 was one that were giving estrogen and progestogen to women. And it was stopped because they noticed the increased risk of heart attacks and stroke in those patients, which was not the desired outcome of the study. So for the safety of the patients, they stopped the study. The things with the study, the WHI study or Women's Health Initiative, is that this was designed to assess if there is a cardiovascular benefit of hormone therapy in older postmenopausal women. Those are patients that did not have any symptoms. And that was actually one of the factors that, to be eligible for this study, you should not have symptoms. And they were older women and they had multiple comorbidities. So they were trying to assess if giving hormones to this population will protect them from heart attack and stroke. So what they found out, there was a trend and signal of increased heart attacks and stroke. So study initial findings were presented at the press conference. And of course, press did run with it. You had huge headlines, hormones will kill you, etc. So nobody wanted to touch hormones after that. But we had lots of analysis of that study and data from that particular study that are pointing towards different data. So we had lots of years, like almost a decade, of huge uncertainty after this study. And what happened in that 10 years after the initial findings of the study were published, before we analyzed the rest of the data from the study, and what kind of consequences that had on a woman's health. The use of hormones in menopause declined by 80%, which was huge. Women were stopping hormones or were never starting hormones. At the same time, we observed the same population and hip fracture increased, the incidence of hip fractures increased by 55%. In the US only, the public health estimates were that up to 91,000 women died prematurely in those 10 years post-WHI because they never started hormones or they stopped too soon. So those are kind of the staggering numbers that we have observed. So we also know now from all that great study and data that if the menopausal hormone therapy is started within the first 10 years after your last menstrual period, risk of heart disease and dying of any cause is reduced by 40%, which is huge, great protection. So I always hear from my patients, what about breast cancer risk? I'll die from breast cancer if I start hormones. So then, there are definitely lots of studies in looking at the risk of breast cancer. So your risks of breast cancer, if you start hormones and stay on them for 5 years, are 1.3, which is a relative risk. So I put this relative risk in a comparing to somebody that had late menopause after age of 55. It's actually sometimes higher risk of breast cancer, even without hormones. If you don't have kids or you had a first child after 30, your risk of breast cancer is higher than using hormones for 5 years, etc. Dr. Simon actually did some analysis in US, and he puts all different kinds of studies that we have with the breast cancer risk. And, anything green shows protection against breast cancer. Anything in red, going lower, it's much higher, shows increases of breast cancer. So in the first line, you see here the estrogen only actually decreases risk of breast cancer versus estrogen and progestin will increase slightly. It will increase breast cancer risk less than drinking alcohol or eating French fries or using heat pads, etc. So it's kind of very interesting perspective. So healthy lifestyle and reducing breast cancer risk is definitely important, but hormones do not seem to have that much of the effect. Also putting things into perspective, here you have the visual of the causes of death in 20th century, why people were dying. The arrow points to a little circle representing by volume, by numbers, how many women died from breast cancer versus people that died because of humanity in wars or being killed by guns or by other people. Cardiovascular diseases kill so much more people than breast cancer risk. So this is just kind of putting things into perspective. So the bottom line with the hormone therapy, with the menopausal hormone therapy, is that this is definitely the most effective treatment for hot flashes and night sweats. If you are having premature ovarian insufficiency or early menopause, they should be used. And again, they could offer the protection for the bone and minimize the risk of osteoporosis. And they will improve mood, joint pain, sleep, sexuality, quality of life overall. And we now know that they do offer some protection for the cardiovascular system as well. So I'll pass the baton to Michelle to chat about something about food and how what we eat affects our overall health.
Okay, so here, oops, sorry about that. We're,
While Michelle is working with the finding the slide, I would encourage you. I would encourage you to type your questions in a chat box, so we can chat after and try to answer as many as possible. So anything that comes to mind, please feel free to put in the chat.
Great, thanks, Regina. So yes, we wanted to talk a little bit more about lifestyle and get down to some of the nitty gritty of what are some of the components that are dietary related that may offer some protection from both symptom management as well as protecting heart health. And so different styles of healthy eating patterns are listed here. One is called the Mediterranean diet, which many of you may have become familiar with or heard about in the news. It's a very plant-rich style of eating with lots of fruits and vegetables, things like nuts and seeds and grains and good healthy fats and fish and chicken. And you see as the triangle tapers up, meats and sweets less often. And there's another eating pattern that has significant literature as well for those of you who are concerned about preventing dementia and staying brain healthy. The MIND diet is really a combination of the Mediterranean style of eating combined with another eating pattern called the DASH diet, dietary approaches to stop hypertension. And this type of diet as well has been shown to offer some protection in terms of cognitive impairment. Very similar in terms of content. The MIND diet does intentionally focus on specific types of vegetables and fruits, for example, and some specifics more around the cheeses, etc., but very similar styles of eating, both of which offer multiple health benefits. The specific foods, when we start to look at eating patterns of which ones offer that protection, they all seem to contain those components of, like I mentioned, fruits and vegetables, quite high amounts, usually 1 to 2 cups of vegetables a day, a cup and a half of fruit a day, nuts and seeds 3 or 4 times a week, legumes 3 or 4 times a week. So legumes being peas, beans, beans, and lentils. Whole grains are actually part of these healthy eating patterns, which sometimes our patients find that surprising, considering some of the research or some of the media coverage they hear about whole grains. So they're quite happy to find out it's okay to eat whole grain bread. And of course, fish, particularly fish with omega-3 fats. Having fish 2 or 3 meals a week is associated with improved health, and lower fat dairy products, milk and yogurt and cheese, as well as ample amounts of healthy fats like olive oil. So in fact, the Mediterranean diet actually recommends up to 4 tablespoons of extra virgin olive oil a day. And so the question becomes is, how do I incorporate all this amazing food into my meals? And the New Canada's Food Guide, shown here on the right with the plate picture, helps to start to give you that idea of planning your plate. How do you section your plate to include more fruits and vegetables on half of the plate, a quarter of your plate being lean proteins from either animal sources or plant proteins, and the remaining quarter of the plate being high fiber whole grain choices. Again, we're not expecting people to eat all of those different fruits and vegetables, for example, but the idea is implying half of the plate being fruit or vegetable. Again, not having to have that much on one sitting, but just showing the variety of options you could choose. So here's a test for you. We've talked about the Mediterranean style of eating or the MIND style of eating, which are both healthy eating patterns. Of the meals that are listed here, which of these meals would be the most similar to that healthy style of eating? Is it meal number 1? Is it meal number 2? Or is it meal number 3? For those of you who picked meal number 2, you're correct. In this case, we actually have fruit like banana on the peanut butter on the whole grain toast with cantaloupe. So you're actually getting fruit choices there. Unlike meal number 3, you are getting fruit choices, but in liquid form or in an added sugar form. So you're having jam or juice, which, because they neither of them have fiber and some of the nutritional benefits may not be the same as actually eating the whole fruit. So for those of you who picked number 2, that is the one that's most correct. In terms of menopausal ABCs, we see a lot of patients coming in for lifestyle questions around menopausal management. So I thought an ABC idea might be easy to remember. Things that we want to avoid that we know may be more triggering of menopausal symptoms, like hot flashes, for example, coffee, alcohol, added sugars, high salt intake or sodium, as well as smoking, all affect circulation and may aggravate some of those vasomotor symptoms. B stands for balance. We're really trying to focus on a balanced, healthy diet, including the foods that keep you healthy for both physical and mental health. So really rich in fruits and vegetables and legumes and nuts and seeds, choosing grains that digest nice and slowly to give us good post-meal blood sugars, and again, the lean proteins and healthy fats. Calcium is always something we talk about when we're talking about menopause. There's significant bone loss the first 5 years after menopause. So we want to be mindful to make sure you're getting the calcium from your food sources, and also trying to make sure that we educate people that calcium is important for many functions in the body, not only for bone mass, but also for improving systolic blood pressure. And actually, calcium-rich foods are a key part of that DASH diet I mentioned earlier that is associated with lowering systolic blood pressure. D stands for vitamin D, which we hope all of you are taking. Your vitamin D, at least 1,000 IUs daily for bone health. In some cases, we need to use more if there's a deficiency. So that's definitely a reason to speak with your family doctor or pharmacist or physician assistant or nurse practitioner or dietitian. All of us are more than happy to talk with you about these options as well. E, of course, stands for exercise. So circulation, we need to keep that circulation very healthy, very flexible. Exercising 30 minutes over 5 days in a week is associated with improved health outcomes around blood sugars, blood pressure, blood cholesterol. And of course, we're focusing on both cardio and resistance exercise, because resistance exercise does help to stimulate the muscle and stimulate bone mass. And that's very important as we age. We really want to focus on keeping everyone strong and promoting balance and preventing future falls. F stands for healthy fats. So again, many of the eating patterns we've talked about today, the MIND diet, the MEDI diet, the DASH diet, all are associated with very healthy fats. Gone are the days where we ate low fat. Nowadays, we're focusing on those good fats that have what we call monounsaturated fatty acids or polyunsaturated fatty acids. And these are just some examples: your olive oil, nuts, seeds, avocado, fish, for example. And of course, I threw fan in there for those of you going through menopause. Keeping that body temperature regulated is always a challenge, and staying cool, dressing in layers, but most importantly, staying hydrated, because we do find sometimes dehydration can actually worsen some of these symptoms you're experiencing. So then we wanted to introduce to you some of the people that we see in family practice that come to us with menopausal related symptoms. And some of these may relate to how you're feeling as well. As a dietitian, I am also always getting referrals from people who are interested in wanting to learn more about what can I eat when I'm going through menopause. I'm noticing some shift in my weight. I'm seeing some weight gain around my abdominal area. I'm finding my sleep is not great. And when I wake up tired, I start to reach for those things that perk me up. So I'll reach for more caffeine, or I'll grab, a chocolate bar just to keep me alert. Many times the women I'm seeing are trying many different styles of eating, sometimes fad diets, in the hope of weight loss. And unfortunately, sometimes restricting their intake, where it's starting to affect the nutritional quality of their diet. In addition to reporting symptoms like dry skin, hair changes, being in a brain fog, and often hand in hand with some of these symptoms, we see things like worsening cholesterol, sometimes diabetes starting as well. Now, Lisa, our nurse practitioner who was going to join us today, is unfortunately not able to join us, but she wanted to share with us what she often sees in family practice, where women are presenting with in menopause or perimenopause, where there's recurrent urinary tract infections, and often symptoms of that, like running to the bathroom frequently. There may also be intermittent yeast infections, issues with vaginal itch, and no improvement when they've had treatment for the yeast infections. Mel, do you want to share what you see?
Yeah, and I think it's probably important to say too is that, we see there's definitely not a black and white presentation for patients presenting with menopause. And sometimes it's just actually a conversation that comes up in a visit that's not even related to why they're coming into the office. But I would say a typical patient that would be booked in specifically for menopause is just someone saying that their menstrual cycles are irregular, and is this normal, and are they going through menopause, or what does this mean? And then that's usually when I would open up a conversation about what kind of symptoms are they having with the irregular cycles, and then kind of diving into more of a history. So I'd say probably the most common presentation is just around the menstrual cycles itself.
Great, thank you. And Dragana.
So again, as a clinical pharmacist, I do see patients that are referred to me to look at the medications for different reasons. So sometimes, we'll see a patient to look at different options for sleep. But then when you look at the patient, is 48 years old, looks like it's perimenopausal, it has a mood swings, not sleeping well at night, waking up 3 to 5 times per night, and usually soaking wet. Only after I asked, she said, yeah, I do have hot flashes, but I'm learning to deal with it. There's nothing I can do about it. And she's looking for something for sleep because that chronic insomnia or difficulty sleeping is leaving her tired in the morning, really, barely making it throughout the day, and then irritable, moody, etc. So I'm not even thinking that this hormonal changes, there are maybe other interventions that will actually help with hot flashes and night sweats, and that will improve sleep and all the other symptoms that she's experiencing. So quite often women do try to be tough, to just kind of, it will pass, it will not last forever, and I can do it. And that is really lots of undue stress on us for something that can be dealt with, if not with hormones, with other interventions. But it is usually related to hormonal changes at that time of life.
So we also wanted to introduce you to some resources that we wanted to share with you. We have done another little short video, just 1 minute long, and Dragana has featured here with one of our other dietitians. So that's something that you can always access on our Hamilton Family Health Team YouTube channel, which has a whole library of different recordings, but we wanted to share this one in particular with you. And then we wanted to talk about what's next, because some of you in the Q&A I can see have questions about how do I approach this conversation with my family doctor, and what do I do if they're not willing to offer hormone therapy. And so we do want to encourage you to connect with your team. We encourage you to connect with us if you have additional questions as well beyond this webinar. We're happy to email you some replies, and we wanted to connect you with, as an example, some other resources for you. So that leads to this question. And in the chat, we do have a couple of people have asked, when is the best time, at what stage of menopause, to meet with our family doctor to discuss if it's safe for one to start hormone replacement therapy? So I'll open that up to you, both of you.
Melissa, I'll start and you jump in. It's even a good idea to start before you start having any symptoms, to maybe a chat with your next physical, or next time you see your doctor, chat about, what their knowledge about the managing of symptoms of menopause or perimenopause is, and what you can do on your own to prevent issues. As Michelle mentioned, good diet, good lifestyle, exercise definitely helps with minimizing different kinds of risks associated and minimizing symptoms. But when hormones go out of normal, then, if you start suffering, it's time to ask for help. Sooner you do it, you actually have better health outcomes, especially cardiovascular outcome. You protect your bone if you start hormone therapy sooner. If you wait too long, you are living through increased risk of heart attack and stroke with just a mere presence of the vasomotor symptoms, which is hot flashes and night sweats. So again, this is something, sooner you start, don't wait, don't try to tap it out. Speak with your physician, with the team, with the nurse practitioner, with physician assistant, nurses, clinical pharmacist, dietitian, whoever they have on team. They all can connect and educate each other how to help you. And again, everybody's different. Hormones might not be best for you, but there are other options that are non-hormonal that will help control those symptoms. Melissa?
Yeah, so I agree with you, Dragana. I think that there's no perfect time. I think when it starts to, when we open up the conversation, it's when it starts to affect your quality of life. I think when it comes to that point, then that would be the point of really exploring whether hormonal options may be good for you, or maybe non-hormonal options. And I think that a lot of women have this misconception that, if I just wait the 1 year without having my period, then my symptoms will get better. Like I just have to ride it out for the year. And that's not true. We know that it goes beyond the time frame of not having a period for the 12 months and then being diagnosed in that menopausal period, that your symptoms can still absolutely persist past that point, even years down the road. So I think just waiting it out is not the best solution. And really the question comes down to, how do I talk to my doctor about it? It's just really booking that initial appointment to open the conversation. That conversation doesn't mean that you need to start treatment. It's just about, are my symptoms normal? How much are they affecting me? And what are my options? And then taking whatever information they give you and doing your own research, and maybe booking an appointment if they have a dietitian or they have a pharmacist, depending on the doctor's comfort with prescribing those medications. And again, there's hormonal options and non-hormonal options. So.
Great, thank you. We have another question similar to this, that if I request to have hormone replacement therapy through my family doctor and they refuse or try to steer me away from this, what are my options? So this is a very, very good question. Can you both share your ideas there?
Lisa, go ahead.
I would just say that there are some absolute contraindications to hormone therapy. So one of the reasons they could be steering you away from it is if maybe you are at an increased risk, or you do have something in your past medical history that may be an absolute contraindication, or maybe a higher risk to start a hormone. And if that were the case, there are the non-hormonal options, and there are a lot of options actually, and you can really tailor these options to what your symptoms may be. If the symptoms are maybe more related to insomnia or kind of mood disorders, then there are medications that are actually used for as antidepressants that are used for treating hormonal symptoms. And there are also some non-pharmacological options too. But I would really say that there at least are options if there are contraindications, and that's why they're steering you away from hormone therapy.
That's correct. And then another thing is that I would definitely like to say that everybody is learning forever, so the physician is learning as well. And if you find that your provider is not giving you a valid reason for not going with the hormones, maybe again engage in discussion. Maybe ask for that provider to educate themselves more about what the guidelines are right now, because global guidelines are recommending appropriate use of hormones. But again, you might not be the good candidate for different reasons. Another option I would suggest is to be really careful if you're seeking help with the hormone prescriptions or hormone medications from other sources, and from online providers or compounded bioidentical hormones, because most of the hormones that are available now on prescription are basically bioidentical. It means they're identical to what our body makes. Compounded do have a place if you cannot tolerate a patch or gel or something, so these same hormones can be incorporated in cream or different kinds of format, but they are not any safer. They are exactly the same hormones we prescribe. So it's a really being very careful with using bioidentical, because you do have commercially available bioidentical that your doctor can prescribe.
Great. So we have a specific question about the hormone therapy. About 3 years ago, Chimera Pro patch was taken off the market. Astellas Transderma was recommended, but side effects of this option made this a less desirable approach. What might be an option?
I'll jump in as a pharmacist, of course. Yes, Chimera Pro was amazing product, and it was once a week. It had different progestogen than what Astellas has. So again, option would be that you speak with your provider to maybe change Astellas dose. Maybe it's the dose related side effects. If that doesn't help, then maybe going to estrogen only patch and using different kind of progestogen to protect the lining of the uterus, maybe even oral progesterone instead of Astellas combination. So there are options that you can discuss with your provider. Melissa, do you agree with me?
I would have consulted you for that, Dragana, so yes, I agree with you.
That's the beauty of working on a team. We can consult with each other. So I'm hoping that both of you could speak to the benefit of transdermal patches and how that has really significantly reduced the risk or concern for cardiovascular disease.
I'll start. Again, Estrogen is available orally as a tablet. It's available as a patch or as a gel or a cream that can be applied through the skin. When estrogen is applied through the skin, it does not go through liver, so does not affect your cholesterol, your triglycerides, and a few other parameters that might increase cardiovascular risk maybe. So if you, for example, have issues with your cholesterol or high triglycerides, or you had some gallbladder disease in the past, your physician will definitely prescribe an option that is transdermal estrogen, not oral. Oral is convenient, and most patients are good candidates for oral, so oral is fine. And then we would monitor your cholesterol if you start oral estrogen. Patches are convenient because they are applied twice a week. And they are convenient because then they give you a bit of a steady state of estrogen. So then if you're, for example, shift worker, or if you sometimes forget to take medication, that might be an easier version. Gel or cream are also good options, but they have to apply it daily.
Great. And Melissa, anything to add there?
No, that's everything.
Great, great. All right, so let's carry on with a couple other. We have a poll. Oh, we wanted to introduce this tool. Did you want to introduce this, Dragana? This may be something they see in some of the practices.
So sometimes, when you go in to see the doctor or nurse practitioner or physician assistant for different kinds of issues, they might ask you these 6 questions. So be very careful or answering them. Be very honest. Changes in periods or maybe no periods at all, it's easy. But again, having hot flashes or day or night, some people say, oh yes, but they are okay, who cares? So do report them if they happen. Any vaginal dryness or pain or sexual concerns, bladder issue, incontinence, issue with sleep or mood, do talk about those, because those will be kind of a screening questions we will ask you to identify the issues associated with the menopause, issues that need to be addressed. And this is a questionnaire that is accepted by the Canadian Medical Association. So it's not something that we just came up with, but your physician should know about it and should be asking you these questions. Melissa.
Yeah, and I'd have to say that this is probably newer, like they will probably see more and more of this questionnaire being asked. And that's because a lot more people are talking about menopause, and a lot more patients are coming in to talk about menopause too. And I do think that this should be a focused visit. And even though they ask you these questions, it's kind of just a starting point, just if you are saying yes to many of these questions, or even one of the questions, that means that there may be treatment for you, and that may open up the conversation. So I think this is a great screening tool that patients may be seeing more and more.
Great. So we wanted to launch a poll to get your feedback. So we've answered the question so far. This is a poll I'm going to launch. It has 4 questions, and it's basically asking if you yourself are experiencing menopausal symptoms, and if you are on any type of specific therapy, or if you've talked to your provider already, as well as did you find this information we shared with you today helpful, and would you like more information? So we'll give you a few minutes to answer these questions and get a sense of what your thoughts are. And then we do encourage you to add more questions into the Q&A. Happy to have, we have a few more minutes left together. Happy to answer any additional questions you might have around managing menopausal symptoms. I just think this is such an exciting topic for us to be finally talking about. I think it's so prevalent, and even as a dietitian, I'm always surprised how often it comes up in our nutrition assessments, how women are commenting about these symptoms, which we in the past had never realized they were so strongly linked with heart issues, and that really managing these symptoms may in fact keep women more heart healthy and protect them from disease. So it's been very informative for us. And now that this is on our radar, we're being sure to be, asking and assessing some of those questions, and then talking about it with our teams and encouraging them to connect with the family doctor for more discussion, or
Absolutely.
Any other team member.
Absolutely. I just want to add, Michelle, it's something with the women, we will be spending longer time in perimenopause and menopause, being very active, working, looking after our kids, parents, working at your job. So there's lots of pressure on women. And sometimes, admitting that we are suffering the symptoms is almost seen as a sign of weakness. So do acknowledge if they exist and ask for help. Because there are lots of things that we can do, maybe hormones, maybe not hormones, but it should be addressed. Quality of life was often dismissed as a valid reason to do intervention. Now we have more strong evidence that's connected with cardiovascular health. So yes, it's not just it's annoying, it is dangerous if you are suffering these symptoms. So seek help.
Melissa, anything else you wanted to add there?
I think the only thing is more, there could be the barrier of the provider being comfortable with the conversation as well. And that could be something that some of the patients run into. And so I think it's just, it may take a little bit more work on the patient's end to bring up the questions and the concerns and be their own advocate. And that's okay, to be your own advocate. And even if it's something that your doctor may not be comfortable with, there could be someone in the team, or they could also refer you to even a gynecologist to have that discussion. So don't let it affect your quality of life, because it shouldn't. Because like Dragan has said and Michelle said, is that you live a lot of your life in menopause. And so, previously 50 years ago, the average life expectancy was a lot different than it is now. And so, people are living into their 80s and 90s, and you want that quality of life in your 50s. It's still a young age, 50s, 60s, 70s. And so you don't just want to just ride it out. I think that it is super important to at least have that conversation.
Yes, 50s are the new 30s, I've heard.
Yes.
Or I like to think that. So we have another question just came up. I'm hoping both of you can share your thoughts here. Thoughts on hormonal IUDs for menopause?
So I'll do first, and then we'll have you jump in. Hormonal IUDs, intrauterine devices, do contain progestogen in it, and they are great to control bleeding or minimize the risk of endometrial hyperplasia or thickening of the lining of the uterus. They do not help with vasomotor symptoms. Melissa, do you agree?
Yeah, I agree with that. And that does kind of allude to another point, is that there is that period of time where someone's going through perimenopause, and when you have that HRT or the hormone discussion, there is still the possibility of getting pregnant. So there is this contraception approach versus the hormone replacement approach, and so that is kind of a deeper dive into that conversation about what hormones you can use. But like Dragan said, is that the IUDs contain progesterone only, so they would not help with the estrogen replacement part.
Yeah. Just wanted to jump in as I'm sitting here connected with all my other networks. I'm getting messages from my colleagues, pharmacists that are listening to the diabetes conference, and they are saying that talk about hormones and diabetes was excellent because, again, there is connection. If you are perimenopausal, postmenopausal, and you use hormones to prevent and minimize vasomotor symptoms, you actually will minimize the risk of developing type 2 diabetes. That is something that is proven. It's not indicated as a reason to start hormones to minimize the risk of diabetes, but if you are on hormones, it will minimize that risk.
Which is great. It was considering all the diabetes education we do. That's fabulous to hear. I have another comment from someone asking they would like to hear about menopause after early hysterectomy. I guess.
So this is something like early hysterectomy, when the ovaries are removed, when you are actually in a kind of surgical menopause early in life. The treatment recommendations by the North American Menopause Society, SOGC, International Menopause Society, is that you start hormones as soon as after surgery. Sometimes the surgeon will actually start hormones prior to surgery, and then you stay on them until age of 51, at which point you will decide whether you're going to continue or not. So you're kind of mimicking your own body hormone production until age of 51 at least.
Okay, another question. What is the most common side effect of hormone replacement therapy, and does it cause weight gain?
I would say just the most common side effects that I hear personally is breast tenderness, nausea, bloating can be a side effect as well. Sometimes headaches, kind of differs with individualized to the patient and what they're on. But I would say probably the nausea and bloating and breast tenderness are probably the most common ones that I hear.
That is correct. And it depends really, as Melissa said, what kind. If it's transdermal, it does not have the bloating and nausea, but it might still cause breast tenderness. That might indicate that dose of estrogen is too high. You want to try lower dose. Another interesting thing that, oral progesterone, the side effect is sleepiness. So if you take it at night, it will actually help sleep. So it's the kind of desired side effect of one of the hormone options. And the weight gain is interesting because hormone replacement therapy, if it's appropriate, will not increase weight. If it's too high dose of estrogen orally, might increase water retention and might increase weight. But again, we usually do not use these doses that were used in the past. So usually we don't see the weight gain with the hormones, but with the hormones, we also observe that there is less of the menopausal weight gain. So these are in studies, and that's the really recommendation by NAMS. When you look at the postmenopausal weight gain, it happens anyway. If you are on hormones, you'll stop it.
Okay, another question for you, both of you, on does hormone therapy work with other hormone issues, for example, like Graves' disease? Melissa, do you want to jump in or?
Yeah, I mean, I wouldn't know the actual, I would probably have to look at the endocrine system to see if that would, my take on that would be that it would not, because you're just essentially replacing the estrogen and progesterone. So it's not affecting those pituitary hormones. That would be my answer to that.
Yeah, and I would agree. In those patients that have other endocrine diseases, most likely actually will need to be treated with appropriate doses and formats of hormones as well.
Okay, another question on hormone therapy. Can it aggravate migraines if one is prone to that? Typically triggered by their menstrual cycle, they said, I guess.
Yes, and that would be the hormone part of it, especially if they find around their menstrual cycle with hormone changes that they get migraines. I mean, hormones in general can increase headaches. It would depend on the full history, like the migraine history, and whether it's migraine with aura, and then you'd have to question if you're going to replace with estrogen as well, like whether you would actually put them on a hormone replacement or not. And you'd really want to make sure that the migraines were controlled before you would add in a hormone.
Yeah, I think it is interesting also when the hormones are started, postmenopause or pre or perimenopause. And another interesting thing is that there are certain hormones that will actually minimize migraines and help control menstrual migraines. So again, this is a very individualized. Progesterone is one that we sometimes use not cyclically, but regularly for patients with migraines to minimize them and avoid large doses of estrogen. This is kind of interesting to point that when you compare the birth control hormone activity, your own production of hormones and hormone replacement therapy post-menopause, the birth control is usually 5 times a stronger activity of hormones than what you produce in your own body. And the hormone replacement is actually even lower than what you produce in your body. So when you put it in perspective, it's depends what we use, what format, what dose.
Okay, we have another question that someone is wondering that her mother that was in her 70s was very healthy, had a cerebral bleed. The doctors were thinking it was related to blood pressure medication, which this person wasn't on anything. And so our participant is wondering, would more learning on that, could this be a vasomotor symptom? And would something like hormone therapy be beneficial or protective, perhaps, of the cardiovascular issue? Is it linked with the reducing risk of cerebral bleeds?
Go ahead, Melissa.
I was just going to say, not bleed. If anything, when we're talking about cardiovascular disease and stroke risk would be ischemic strokes, not hemorrhagic strokes. So we'd be talking about more of the plaque formation in the arteries versus bleeds or tend to be a rupture of possibly an aneurysm or just pathological. But when we're talking about strokes or protection, we're talking about the actual artery. So we'd be talking about ischemic clot.
There's some great questions. So everyone's saying thank you, thank you. This is very helpful. So I think on that note, I think we will wrap things up and just say thank you to all of our participants and thank you to our panel here. This is wonderful learning about this information. I think it's very helpful. And I look forward to more on women's health. And from our survey, that our poll that all of you answered, many of you are actually very interested in learning more about vaginal health, which may be another webinar we offer in the future. So thank you, everyone, and have a lovely afternoon.
Thank you.
Bye-bye.
Thank you.